Hello, mic test 1, 2, 3. Hello, mic test 1, 2, 3.
Sama clarity. Voice पक्का बोलो.
My audio, videos. What happens? I don't know.
Suddenly, I don't know.
It's okay, don't worry.
Yes, ma'am, you can use this.
Yeah, I don't need to use that. I only have this slide. Only this one slide has to come for me. I don't need anything else.
Okay, okay, okay. Okay.
Hi, can everybody from the back move forward, please? Good afternoon to everyone present here and those joining us online. On behalf of the St. John's Medical College Alumni Association, welcome to the 42nd Dr. Jayashree Thomas Memorial Oration. What makes this special for us is that we are celebrating the Golden Jubilee of our hospital with 50 years of compassionate service, medical excellence, and community impact. I would like to extend a warm welcome to our director, Father Jayashree, our CMS, Dr. Varghese, and all the faculty here. Dr. M.J. Thomas, Dr. Maya Thomas, and the family of Dr. Jayashree Thomas were joining online. And of course, to our orator for today, Dr. Vikram Matthews, Director, CMC Vellore. A warm welcome to St. John's Medical College, and thank you very much for accepting our invitation to deliver this oration. The Dr. Jayashree Thomas oration has had many esteemed orators, both from St. John's as well as CMC, since its inception in 1984. So I would like to first call Dr. Rajalakshmi, Head of the Department of Pathology, to speak about Dr. Jayashree Thomas.
A very good afternoon to all the dignitaries, the guests, and the onlookers present here today. Jayashree Thomas, née Nair, entered this campus as a Johnite of the batch of 1968, and she completed her MBBS in 1975. An outstanding student with a consistent record of academic excellence, she secured first place in anatomy, physiology, forensic medicine, and obstetrics and gynecology. She was recognized as the best outgoing student and awarded the prestigious Pope Paul Prize in 1974. In addition, she received the President's Silver Medal for securing the first rank among all the women candidates appearing for MBBS examination in Bangalore University the same year. From her undergraduate years, Dr. Jayashree nurtured a deep interest and love for pathology. She joined the department in 1975 as a resident and was soon appointed tutor in 1976. During this period, she completed a research project titled Fallopian Tube Morphology in the Normal and Abnormal Menstrual Cycle in South Indian Women, which was not only published but also earned her the coveted Dean Louis Montero Research Prize in 1977. She also presented a paper titled Leiomyosarcoma of the Kidney at the State Pathology Conference. She applied for the MD Pathology program at CMC Vellore the same year. In his glowing letter of recommendation, Professor John Thomas wrote that she has attained the capability to report surgical biopsy slides on her own, which is witness to her brilliance even before she entered the course. Her stellar performance in the MD University examinations at CMC is spoken of by her colleagues and juniors till this date. She returned to St. John's as assistant professor in 1980, and within a short span of 2 years, she published 6 research papers, 4 of them in international journals, underscoring her exceptional intellect. Beyond her scholarly accomplishments, Dr. Jayashree is remembered as a warm, gentle, and caring colleague, as well as an innovative teacher. Her attention to detail and love for learning remain evident in the collection of books graciously donated by her family to our department library. The beautifully handwritten notes at the end of each chapter are still a treasure to behold. Cooking was another of her passions, and her colleagues eagerly anticipated the treats that she used to prepare. Her sudden and premature departure from this mortal world in 1982 did not dim her glow. A brilliant student, an esteemed colleague, and a loyal, much-loved friend. This is the sentiment that was shared by all those who had the privilege of knowing her. In her cherished memory, this SJMC Alumni Association instituted the annual oration in 1984. The first oration was delivered by Professor Anand Date, then head of pathology at CMC Vellore, and the most recent 41st oration in 2024 was delivered by Dr. Bernadette Nirmal Kumar. The song may have long ended, but the memory lingers on. It's been absolutely my privilege to introduce Dr. Jayashree today, and I thank the Alumni Association for this opportunity. Thank you.
Thank you, Dr. Rajalakshmi. To introduce our orator, I would like to call Dr. Sharat Damodar, currently Clinical Director at Mazumdar Shaw Medical Center. His association with Dr. Vikram Matthews spans many years. He also is both Johnite and CMCite.
Thank you, Anjali, and thank you, Robert, for giving me this little opportunity to have the honor of introducing Dr. Vikram Matthews, whom I have known since the past 20 plus years. Now, it's a solemn occasion for me because I also happen to have kind of seen at least Dr. Jayashree when she was in the campus, because she was my mom's colleague, Prema Damodar. And I at least remember, running around as a small kid having seen her, which is what I mentioned to Dr. Thomas. And it's even a bigger privilege to also now introduce the speaker for this little session which we're having today. Right. So this is Dr. Vikram Matthews. Actually doesn't need too much of an introduction, so I'll tell you the little bit, which is, from here and there from his classmates, which I can tell you. This is his first picture, okay? So a little history about him. He studied in Bangalore, so he's a proper Bangalore boy. Germans, and then St. Joseph's College, and then went on to Vellore to do his training there. He was the students' representative president of the association, and thereby he's in that parade where he leads the Jasmine Garland ceremony, if I've got it right. Okay, so that was Vikram in his early days. And then this is his badge. I don't know if you can identify him. I should probably ask Vikram to identify. I also struggled. I think he's there in that corner there. And just very close to him is Mrs. Matthews also, if you can see that. Okay, so that's the same batch there, just below him, Dr. Urmi, and that's his college photographs there. After that, we all recognized Dr. Vikram with his nice thick mush, which is actually missing here today. He went on to do his DM clinical hematology. He was the first DM candidate from the country to have secured the DM in hematology. And just last year, we celebrated 25 years of the DM Hemat program. And this is something which all of us are very proud of at trained at Vellore. Subsequently, he went and spent time at the St. Louis Hospital in the US, where he did a postdoc fellow and a BMT fellowship as part of his sabbatical, and then got back. This is current Dr. Vikram's photograph. You can see the change there. He's become more sterner, I think. Okay, and then went on to become the head of the department and then director, which he is currently holding that post. Now, when they told me to do a 5-minute introduction for him and I tried to look at his CV, it ran into 35 pages, okay? So to compress that into 5 minutes is truly difficult, so I'll just put some of the highlights. You can see he's been a topper throughout his MBBS career in the top 2, 3 throughout. He's won the best incoming student. He's also been the best outgoing student of his batch. He's been the best outgoing student in the MD batch. And I don't think they had one for the DM hematology course, but I think as a consensus, if you put it together, he's the best outgoing of all the DM hematology batches from Vellore. Right. Publications are more than 300, okay, huge numbers there. And these are the highest cited articles which he's published. And clearly there's an area where he's focused a lot of his work. He's one of the world's first known person to actually trial out arsenic trioxide in APML. And a lot of work was done in Vellore, and now that's come up as a standard of care, and a lot of it is owed to him. And we were all part of that little, running around time when we were collecting these arsenic bottles from the pharmacy because it was manufactured at Vellore, and then we had to go and get Vikram's signature to sign off so that we could give it to the patient, because it was so precious at that time, because nobody manufactured arsenic at that point in time. Not available commercially. So you had to have it manufactured in-house. So that's a great thing which he's contributed to the field of APML. Is one of his favorites in the field of AML. And clearly you can see all his publications there in the top, 4 or 5 of that, highly cited publications. And then I have to take a little time here and say some of his best publications, don't see the bias there, okay, are clearly in the field of AML, there is transplant, there is Dapsone in ITP, first paper from Vellore. It's really, a landmark paper there. And then something on the fungal infections in patients with acute myeloid leukemia. Now he's a review for a lot of the Indian journals, most of the Indian hematology journals, and a lot of the international journals as well. You can see the big list there covers both adult and pediatric, transplant and non-transplant journals there. This is a citation, so this tells you a lot about the amount he's published and achieved. So the H index, you all can go and figure out what that is, okay, of 45 is very high, and I-10 citations more than 10 for those particular articles is 151. So a lot of them have been cited in his literature. I think a big round of applause for that. In addition to his academic appointments, there are a lot of his appointments beyond Vellore. In a lot of areas, he's also been examiner for both PhD and the DM students and the DMB programs. He's been on various committees for the ICMR, the task force, and some of the expert committees even from the CDSCO. He's also been part of the national committee which drafted guidelines for hematopoietic stem cell transplant in the country, and this has come out from ICMR there. Other positions gradually, as you can see, over a period of time, went on to become associate director and then went on to become the director. He also is somebody who organizes our annual CME for the alumni of, the CMC pass out from hematology, and also the founder member of the Hematology Cancer Consortium, which is a big organization of multiple centers across the country collecting data, collating it, and actually putting it together. He was also there when the new campus of CMC Vellore came up, a big, massive campus, which was inaugurated by the CM at that point in time. And this is what the campus looks like, so much different from the traditional old campus, which we all have been used to. Now, this is another area, don't miss the hockey stick name on that, okay? So I just Googled Vikram and hockey, and this is what I found, okay? So he's been a state player, apparently a brilliant goalkeeper from whatever Uday Zak told me. He actually won a match with Germans versus Josephites on a penalty shootout thanks to his brilliant saves at that point in time. He's also been Sportsman of the Year, represented the state, and in his CV mentions that he still has that passion going. His musical preferences are there for all of you all to see. ABBA, Pink Floyd, Deep Purple, Beatles. And I'm sure I could push in some Bryan Adams and Dire Straits also there, as his talent there. Last few slides. So this is Vikram at our last alumni meeting. 25 years of DM hematology program. He's very down-to-earth, casual. What I'm holding is not a glass of wine, it's just grape juice, not yet fermented. Okay, just having a little chat. And then last year's CME, in spite of his busy schedule as a director, he was there for the entire day for our, CME program there, sitting there and participating. And then to top it all with the last pick here. So this was the ad shoot for Samsonite, when both of us participated and we got our retirement corpus from that. No, I'm joking. This is a medical rep who ate our brains and wanted a pick at Nagpur airport during our hematology conference. Okay, so that's my last slide here. That is the intro for him. Let's welcome him with a big round of applause.
Thank you, Dr. Sharat, for that wonderful introduction. And now, without further ado, Please join me in welcoming our orator for this 42nd Dr. Jayashree Thomas Memorial Oration, Dr. Vikram Matthews.
Is it coming up? Is that mine or? Yes, sir. This is the pointer. Yeah, it's okay, don't worry. I'll manage it from here, don't worry. This is the pointer side. No, I don't think I'll need that, okay. Okay, good evening, everybody. It's really a joy and a privilege to be here. Thank you so much to the organizers for inviting me. Thank you, Dr. Thomas. It's a privilege to be here at this oration, and to the Alumni Association. St. John's is a special place for me, as I'll show you in a few slides later. And every time Dr. Sharad introduces me, my heart slips a few beats because I'm not sure what he's going to say. But thank you for being nice, Sharad. That was a very generous introduction. With that, I'm going to basically talk for a little while, and I'm going to talk a little bit about background, and I'll go straight away into acute myeloid leukemia. I'll talk about challenges with acute myeloid leukemia, and I'll tell you a little bit about the arsenic trioxide story. It really is a fascinating story, you know. Moving from there to the key aspects of this conversations today is on metabolism, AML, and some strategies that we are planning to go forward with, and some early preclinical data that has been published. And I'll show you some unpublished preclinical early phase trial data. So when I talked about background, I'm talking about my background. I'm a Bangalore boy, as all of you all know now, since Sharad has introduced us, and that's me there. If you can see me with the pads over there, this is St. Germain School. I'm a St. Germanite, and I can see lots of eyebrows going up, but proud Germanite. It's a great school, and I think it really imparted a lot to me. There is so much I actually owe to that school. So this is the boys' high school hockey team. I think it's one of the best hockey teams we ever had. That's me over there, sitting over there. And this is a very special person called Father Mervyn Coelho. I really believe that he was my mentor. You know, I was 7th standard playing in the 10th standard big boys game. And that was, you know, nowadays it doesn't seem much when you're small. When you're small, 7th standard playing with the big boys is like pretty big deal, you know. And he saw something special in me. And he took me under his wings and he said, "You're good," you know, and I felt special, you know, and he really made me feel special. Came from a lower middle class family. You know, games was not, they sent you to school to study, not to buy hockey sticks and kits. And Mervyn Coelho bought me my first kit. There's so much I owe to that person, you know, and he died so young. This team, it's unbelievable. Everybody marked in red over there went on to play for the state. That almost, you know, with the exception of about 2-3 people, the entire group that you're seeing over there went on to actually play for Karnataka State Juniors. And that person over there is Jude Felix, who obviously went on to play for India. And the person next to him is Noel Reskina. He's an alumni of St. John's. You know, he was such a dear friend to me when he was senior to me in college. A wonderful person. He passed on early, and I understand there's a tournament named after him right now. So that's Noel Reskina. There was no one who could take a penalty corner better than Noel Reskina. I don't know if anybody's ever played with him. He was just an amazing person. I could not resist this. I own one of these, just to tell you that we consistently used to beat St. John's. And I was also curious, the St. John's is SAIN John's. I don't know whether the alumni those days didn't have too much money for the medals or I'm not sure what the story behind that is, but that's the actual medal, yeah. Okay, so moving to acute myeloid leukemia, this is a bubble diagram that just illustrates to you on the y-axis, it tells you the average age when patients are diagnosed with a disease, and it tells you the survival. So let's take acute lymphoblastic leukemia, for example. Relatively small numbers actually, but excellent survival. On the other hand, you look at AML and MDS, we put together a large number of patients. They are much older, as you can see on the y-axis, and the survival is really in the 20-30%. You'll see individual center data that looks fantastic, but from a large population-based data, not good, okay? So the incidence, median age, male-female ratios, all this data is from the US. We don't have very good Indian statistics. It's a very expensive disease to treat, not because the individual drugs are expensive. Once you treat the patients, the side effects they develop and the complications they develop and the kind of supportive care, you're looking at 30, 40 lakhs of support if you want to go through an allogeneic transplant and really aim for cure. That's terrible, in a country like ours, So the vast majority of patients in reality in India don't get treated. If you really analyze the data, we have a large registry data. In my estimation, I don't have good figures, less than 1% of people who need a transplant in India actually get a transplant. It's a pretty sorry state of affairs. And for those who are interested, you can go and look up this article that we published from CMC looking at real-world data on acute myeloid leukemia. The vast majority of patients who come to CMC are sent away because we're a not-for-profit. We can't take care of everybody, and we refer them to government hospitals. In this paper, we followed up every one of them. Every one of them died. They really didn't get any great treatment, The scenario has changed a little bit. And one of the main problems with AML is they all relapse. So why do they relapse? There are broadly two themes, okay? One is basically the clonal architecture of AML. If you look at this axis, this is the time of a life of a person. And this is, say at birth, he has X number of hematopoietic stem cells. As you get older, at some point in time, you develop what is called clonal hematopoiesis. One stem cell becomes more dominant than the others. Okay, but you don't have leukemia. That stem cell is the dominant population. All your cells seem to come from a few mutated stem cells, which you acquire as you get older. Then somewhere along the line, you get additional mutations. So at the time that you are actually diagnosed in life to have AML, you actually have 3-4 clones of AML. And even if you have a targeted therapy, say against one clone, so often we do what are called qualitative tests. We say FLT3-ITD positive. It does not mean to say every blast is positive. So when you use a targeted therapy, you may be actually hitting only a subclone of the disease and not everything. And even when you monitor the disease, you may be only monitoring a subclone and not the entire clone. And when the patients relapse, they often pick up new clones because treatment itself induces more genetic instability. And so this is a vicious cycle. So the vast majority of patients, and as you get older, your chances of relapsing is much, much higher. The second concept is within this AML, all the cells, in addition to being mutationally different, there's a subset of cells which we call leukemic stem cells. These cells are like quiescent cells. They just lie down quietly. They're not naturally proliferating. And therefore, they're not susceptible to chemotherapy. For drugs, for cells to be susceptible to chemotherapy, for the most part, they need to be proliferating. It's at that point in time their DNA is exposed and they're vulnerable to DNA damage. When you have a cell lying very quiescent, like the medical student sitting at the last row on the bench, nothing in the world is going to shake him. Nothing is going to damage him, So that's it's like, that's how it will be. And you accept it. And when we treat disease, all the bulk leukemia goes away. And you get your disease below a threshold where you can't detect it anymore. But actually what you've done is you very efficiently got rid of the bulk disease, but there's a large number of leukemic stem cells which you can't detect, which are still there. And the whole objective, and this is what, they lie in the microenvironment in the bone marrow, and this is what is going to come back as relapse, right? And so we have to have strategies to hit these leukemic stem cells, okay? With that background, looking at the cost, and the cost is mainly because of off-target side effects. So when you give a drug, you have mucositis, you have lung damage, you have liver damage. So you want drugs that are very targeted, that they hit the leukemic cell. In addition to that, you want them to hit the leukemic stem cells. So if you look at the way the world is going, there's a number of targeted therapies that are available, and there is also a concept of intensifying therapy. In India, intensifying therapy further is not an option. Even with the existing intensification, the amount of side effects and toxicity we get will kill a vast majority of patients in many centers, okay? So targeted therapies, I told you the limitations. In addition to the fact that they're hitting subclones, the common theme is they're all extremely expensive and very few people can afford them. And this is actually just it's an old slide. There are many, many more new agents that are coming around. So what's the definition of targeted therapy? This is what pharma will tell you. Targeted therapy is precision cancer treatment using drugs to attack a specific molecule, like a mutated gene or proteins that drive cancer growth, okay? Down the line, I'll bring this up again, and I'd like to challenge that definition, okay? So our challenge is in this country, we have to be context specific. We can't copy paste guidelines for us. You know, our treatments are different. Doesn't matter if somebody's getting 90% survival, you're not going to get it. And if you use the same thing they use, for certain you're not going to get it. So our challenges are different. We need data. We need good, honest data, which is actually very difficult to get. We need targeted therapy with minimal off-target effects. These are our goals. We need rational and evidence-based therapy, which is based on our own data, and we need regionally relevant data. Actually, we've achieved all of this for one particular subset of disease called acute promyelocytic leukemia. Acute promyelocytic leukemia is a small subset of APML where all the things that I've listed over there, we have actually achieved. So that takes me to the arsenic trioxide story. So arsenic trioxide has a very colorful history. It's the drug that's been in the pharmacopoeia for the longest time. People have been using it forever, okay? It gained popularity when it was the cure for syphilis. You know, the adage, you know, one night with Venus and the rest with arsenic. You know, that was the old adage that went around at that point in time. It has been used for CML, it's been used for trypanosomiasis, it's been used for many other illnesses, all transiently. It's a non-specific cellular toxin. So if you give enough of it, you'll kill anything, okay? So when they removed Napoleon from the grave in the island and brought him back to the mainland, what was the exclamation when they saw his body? They said, it's a miracle. He looked like he was untouched. Apparently, the story goes he was poisoned with arsenic. Even the bacteria won't touch him, you know. So they had to bring him back and bury him on mainland France. So in the pre-arsenic era, when there was already very effective therapy with atra and anthracyclines, we used to have patients we would treat. This is the early 1989, 1996. We would treat and we would send away saying palliation, God bless, and take care, and the comfort measures, etc. And they would come back 6 months later absolutely well, okay? And this happened repetitively a few times, and they were all going to this Vaidya Balandro in Dehradun, and they were getting a therapy, and it was called Rasha Shastra, it was in heavy metals, and they were actually getting cured, and they were coming back complete. So it was just flabbergasting, But the problem with this is they did not know the dose, they did not know how to give it. So once they started, they continued for lifelong, okay? And then you ended up with problems. You ended up with arsenic keratosis. Okay, and arsenic keratosis and secondary malignancies. Okay, so it's actually, these are the better pictures. The others are terrible, it's just really extensive keratosis and secondary cancers. So when this concept came, that's around this time, the Chinese actually published some data showing that it may be effective. So it's fascinating, that this could actually happen, and we did not have an explanation. And of course, when we started with arsenic, there's always this concern of toxicity, how can you use a poison to treat? So if you go back to the slide that I showed you initially, Paracelsus 2,000 years ago, or maybe 100 years ago, he's not that old, said, everything is a poison. It's only the right dose that differentiates a poison from a drug. So if I have to give anthracycline at 0.5 milligrams every day for 3 years, for sure the person will develop a cancer, right? So it's a question of how do you use therapy that makes a difference. So we now know that actually arsenic trioxide has a fairly specific effect on the oncoprotein. There's an oncoprotein called PML-RAR that drives APML. We know that the PML, the arsenic trioxide, binds to the cysteine residues on the PML domain. I'm not, you don't have to get into the fine details, and that polyubiquitination leads to recognition by the proteasome system and degradation of the oncoprotein, and that to some extent. But in addition to that, arsenic has pleiotropic effects. It also increases raw stress, specifically in the cancer leukemia cells at the dose that it's given. And therefore, it brings about this very, very effective kill. Okay? So when the studies came out from China and we actually started using arsenic trioxide, okay? So this was an early approval that I got. I'm not sure if you can read it from here. It says 18,000 rupees, okay? That was in 1999, was sanctioned from the internal grant. It's a pathetic amount. It was pathetic even then. It's not that its time has changed it, but anyway, we had enough of that to make a little buy arsenic and make the arsenic. Actually, we made the arsenic in-house. And it cost us about, about 18 rupees per vial of 10 milligrams. In those days, the dollar was about 36. You know, the way it's going now, I don't know what it is. But it was about 50 cents to make 10 milligrams. You know, extremely low cost, and we could give everybody. We were treating APML, we were treating only about 10% of APML before we had this therapy. You know, the rest of them could not afford the standard of care in a highly curable malignancy, which we knew was curable. We were sending home them to die. And so that is the cost. After all these studies in China, we had published our data, then Memorial Sloan Kettering filed a patent and actually got a patent in North America and Europe. Okay, so all this story about, you know, how much of research is done, all that, you know, take it with a little pinch of cynicism and maybe a bucket of salt, but not arsenic. But anyway, for the arsenic part of it, once the data was filed, can you imagine what the cost of arsenic is today in the West? One 10 milligram vial of arsenic trioxide. Anybody wants to just take a shot? Costs 10 milligrams, except Sharad. And not all the oncologists. Huh? Costs $600 for 10 milligrams. So paradoxically, it is the most expensive drug for APML in the West. It's the cheapest therapy because we had to transit to the industry because we could not continue manufacturing it. It costs about 800 rupees or 500 rupees right now. And for the vast majority of the world, this highly treatable disease, the drug is not available. For most of Africa and many countries don't have access to arsenic trioxide. It's crazy. You know, they're still sitting in the old ages. So anyway, we started this clinical trial. I'm not going to go to inclusion-exclusion criteria. It wasn't just arbitrarily designed. Fair amount of reading, thought went into designing the study, the induction, the consolidation. We had a maintenance phase, etc. Okay, and this arsenic trioxide is manufactured in our pharmacy by Sister Theresia Ma. I don't know how she landed up in CMC, but thank God she landed up in CMC and not in St. John's. She came to St. John's and she was in the pharmacy, and I used to work with her, and she used to very meticulously manufacture this, do all the toxicity studies and the release criteria, etc., and pack it, etc., you know. And that is Sudhir Kumar, who received the first arsenic trioxide in 1998. And as would be for any researcher out here, you start with a research project, and the first patient, everything that can go wrong will probably go wrong. This guy on arsenic trioxide, first 3 months, he had a CNS disease, and everybody said, oh, look at this guy's doing all this rubbish, you know. And then we treated him with just radiation arsenic trioxide. He's now 3 decades with 3 children, absolutely well. So it's been quite a journey. From 1998, in 2006, we published our data, got a lot of attention in the international media, and they talked about arsenic trioxide upfront. Before that, if you go to a Western conference, they look at arsenic trioxide, you know, it's only for the poor people, you can give some arsenic, you know, maybe you have to give all the Petima trials, which were very intensive, you know, they really, really looked down on you if you talked about arsenic. And then we published our long-term data, and there's been a lot of publications, you know, on the toxicity profile, effect on pregnancy, what is the long-term effect on cancer, because when we started this, you know, again for young researchers, when we started this, the amount of pushback, you know, how can you do this unethical stuff? These patients are going to get cancer, they're all going to die. You know, it doesn't matter that you send 90% home to die without any treatment, but if you try to treat them, you know, it's a problem. You know, so we had to systematically study all this. We demonstrated way ahead of the world that additional cytogenetic abnormalities, additional FLT3 ITD does not matter. For those who know AML, APML has the highest incidence of FLT3 ITD, but it makes no difference if you give arsenic trioxide. No second malignancies, fertility was preserved. After the first 3 weeks, these patients would be on the outpatient, no admissions, no hair loss, no mucositis, no nothing, you know, for the most part. And then, you know, look at the timelines. 2013, a randomized controlled trial comes out almost a decade later, and it proves that arsenic trioxide with ATRA is superior to chemotherapy, you know, and the world changes, okay? And we changed our practices to some extent also. We modified our data. We added ATO, ATRA. Today, that's our survival curves, for patients per protocol. Some patients come very sick with IC bleeds, you can't treat. But anybody we can treat, we are looking at 90-95% cure. We will not turn away a single patient with APML unless there's some serious social support issues. Finances, whatever, you can raise the money to treat these patients. So it's really been an amazing journey that, you can today treat every single, and across the country, I think APML is reasonably well treated. So let's look at targeted therapy. So is this targeted therapy? So in my opinion, arsenic trioxide and ATRA is the ultimate targeted therapy. It does not target a specific molecule or a gene, but it is so specific for the cancer cell. It hardly hits anything. You do get some neurotoxicity, some transient transaminitis, nothing that is earth-shattering, So in my opinion, this is another approach in terms of targeted therapies. Lots of patients, lots of people on the way, young girls becoming big with their marriage pictures, married children with ladies who have been treated with their children, and of course, Sister Teresia. Now, the real world with conventional chemotherapy, even with ATRA and chemotherapy, there is still a high incidence of early deaths. That's deaths within the first 10-15 days. And often that happens when you start ATRA. When you start ATRA, or all-trans retinoic acid, which is a type of vitamin A, you actually get an abnormality in the cell called netosis, which predisposes the patient to have leaky capillaries that leads to a condition called differentiation syndrome and also predisposes them to have IC bleeds. So this is one condition for people who on the clinical side will tell you, normal PT, normal APTT, platelet count above 50,000, fibrinogen almost normal, and fellow suddenly drops dead with IC bleed. And so we really didn't understand that. And a lot of that has to do to some extent with the dose of ATRA. Now, both the dose of ATRA and arsenic trioxide did not follow conventional pharmacokinetic studies of dose, phase 1 studies, the dose finding studies. Somebody gave a dose and everybody used that dose, and it has never been challenged. And so there are a lot of in vitro data that suggest a much lower dose of ATRA is more than adequate. In fact, even today, all the Chinese studies use ATRA at only 25 milligrams per meter squared per day. All the Western studies have used for ATRA at 45 milligrams per meter squared. All the Indian studies, at least our studies, I can't say all of India, and the Chinese studies will use arsenic trioxide for the most part at a fixed dose of 10 milligrams. While the West would go at 0.15 milligrams and use much higher doses. So if you're 100 kilograms, you'll end up with almost 20 milligrams of arsenic a day. And you have terrible toxicities, okay? And of course, so they won't listen to you, so we have to do a study. So we've opened a phase 3 open-labeled trial. This is under a group called the Hematology Cancer Consortium. It's a wonderful group of people who share data and are partnering in studies. This is a randomized controlled trial looking at challenging the dosing. So we've randomized between 25 milligrams per meter squared and 45 milligrams per meter squared, fixed dose of arsenic trioxide. The study is enrolling patients, and we hope that in the next 2-3 years, we will have completed enrollment and answer some of these questions. So moving to metabolism, okay? It's another fascinating field, okay? Mitochondria. Did all of you all know that the mitochondria probably arose in our body from fatal endosymbiosis? We were not born, at least protozoa are not born with mitochondria. Somewhere along the line, we got infected with an organism that looks like a mitochondria. And then it became convenient for the cell and the organism to live together. That is endosymbiosis, okay? And which is why the mitochondria divides at its own pace. In a cell, it can multiply by itself, it can divide by itself, it has its own DNA. Its inheritance is only maternal because you only get your maternal mitochondria. You don't, the sperm does not have, the DNA does not have anything. There's no real cytoplasm there, okay? So the very fascinating thing is the organism that it closest looks like is rickettsia. And it's very fascinating. The drugs that you use to treat rickettsia will also damage the mitochondria, especially the tetracyclines, etc., okay? So this is a picture which I'll come back to a little later, okay? This is a picture of an AML cell line staining for the mitochondria, showing you it's rich in mitochondria, the AML cell lines, okay? And this is a slide that I'll come back and I'll show you the effect of treatment of some drugs. But here we have to wade a little into biochemistry. Biochemistry is such a lovely subject, the way they teach it sometimes, I hope there are no biochemistry teachers here. But, all I remember my biochemistry days was, mugging up these cycles and cycles and cycles, I don't know, it made a difference to man or beast, but we just studied it, and you went there and, had all these mnemonics, and some of the mnemonics were from men's hostel, you can't even repeat it. So this is, so if you look at the energy pathways, you have glycolysis and you have your Krebs cycle, okay? But look at it carefully. When you get glucose taken into a cell, if you don't have oxygen, you go into anaerobic glycolysis. So basically, your pyruvate gets shifted into lactate, and the lactic acid is broken down by LDH. So when you have high LDH, it tells you that there's a lot of anaerobic glycolysis, and I'll come to why that is high in cancers. When you have adequate oxygen, adequate nutrition, you go into aerobic glycolysis. Your pyruvate gets shifted into the mitochondria, gets transported to the mitochondria. Remember, we are talking about a 6-carbon molecule at glucose getting dropped down to a 3-carbon molecule at pyruvate. That goes in, and that gets into the Krebs cycle. Okay, and there's a reason why the Krebs cycle is a cycle. Okay, the Krebs cycle can be fed by glucose, it can be fed by amino acids, it can also be fed by fatty acids. So anywhere things can enter into that cycle, okay, and then it gives rise to energy. And we'll talk about a little bit more about the energy. But when you go through the pathway that is aerobic, in addition to the Krebs pathway, you go through what's called the electron transporter chain, which I'll show you in the next cycle, in the next slide, which is the OXPHOS mechanism. And this whole thing, mitochondria, from the time my child is in 8th standard, they'll say powerhouse of the cell. You come to final MBBS, powerhouse of the cell. But there's much more to the mitochondria than powerhouse of the cell. So it's really, really, really fascinating how the mitochondria functions. Okay, so if you look at the mitochondria, the membrane, you have an inner membrane and you have an outer membrane. Okay? And the whole objective is that you have to have a gradient, and this intermembrane place has to be enriched with hydrogen ions, okay? And when you don't have that, you have a problem. So what happens is fatty acid is very important. I'll come back to fatty acid later. Now, if I look at that mitochondria a little bit more detail, I tend to get carried away a little bit, so please bear with me. Okay, so you have the inner mitochondrial membrane, the outer mitochondrial membrane, and you have this entire electron transport chain called complex 1, complex 2, complex 3, complex 4. Okay, to break it very simply, every time the pyruvate, every time the electron gets activated in complex 1, okay, by a reaction, it gets a higher energy level, and that energy level is transported to complex 2. Okay, the electron is transported. And when you transport into complex 1, when the electron is transported into complex 1, there's a pore over there which pushes the hydrogen molecule outside into the intermembrane space. The same happens with complex 2 and in complex 4. Now, at the end of the result, what happens is you have a massive buildup of hydrogen molecules in the intermembrane space. And then from that intermembrane space, the hydrogen moves through a pore, which is the ATP synthase, which literally looks like a motor. Okay, every time a hydrogen ion moves through the ATP synthase back into the cytosol of the mitochondria, literally it rotates. And when it rotates, on one arm is ADP and on the other arm is phosphorus, and they bring together. Okay, and it forms ATP. Okay, so it's literally this electron transport chain is required. And in this electron transport chain, you need oxygen for the last part to receive the last electron before it can actually can build up the enough amount of hydrogen over here. Okay, so this is why it is called oxidative phosphorylation. Okay, while the other phosphorylation that happens in your Krebs cycle is called substrate phosphorylation. It's not requiring oxygen. It's just requiring the kinase enzymes that are involved over there. Okay, so and it's really interesting if you look at the numbers. In an AML cell, in a leukemic stem cell, you may have 200 to 800 mitochondria per cell. In a blast, you can have 2,000 mitochondria, and every mitochondria has 10,000 to 100,000 of these ATP synthase molecules. So just imagine the complexity of this. And every time an ATP is used, it activates a kinase molecule, which can then do its phosphorylation activity and also generates heat. Okay, and that's how your ATP is your currency. Okay, so there's a saying, life is not about love and war, life is about phosphorylation and dephosphorylation. The whole of cellular biology is about phosphorylation and dephosphorylation. Okay, another difficult topic, in that mitochondria, So you now know that you have to maintain this intermitochondrial gradient is very important. If you imagine if you damage the outer membrane, okay, and all the potassium, all the hydrogen molecules leak out, there is no longer a gradient and there is nothing to drive the ATP synthase anymore, okay? So all your therapies that are targeting the mitochondria are basically causing damage in the outer mitochondrial membrane. As soon as you cause damage to the outer mitochondrial membrane, there is no more gradient. All the hydrogen just leaks out. And if the hydrogen leaks out, the ATP synthase cannot function anymore, okay? So it's almost as simple as that. And so to maintain this entire system in the mitochondria intact, there's a whole lot of proteins called anti-apoptotic proteins. You don't need to get into the details of it. They're like BCL2, MCL1, and some cells require more of one type of anti-apoptotic proteins than the others. You can leave it at that. AML, for example, requires BCL2 as the anti-apoptotic protein, predominantly. Okay, there are other cells may require other things. Okay. Now, normally, there's another two proteins called BAX and BAC, which when they heterodimerize, which I can take you to the next slide, they actually form a pore on the surface of the mitochondria, and all the hydrogen ions and the cytochrome C leaks. There is no more a gradient, there is no more ATP synthase, okay? So normally, the BCL2 sequesters the BAX and BAC. What does the system remind you of? Anybody in biology, what does this remind you of? Proteins come together, form a pore, and then everything starts leaking out. The complex, you know, the entire complement system works on exactly the same system. Only thing is, this is on the surface of the cell. Once something is activated, there's a series of proteins that get activated. You form a complex on the top of the surface of your cell, and then everything starts leaking out from the cell, and the cell dies. Okay? The same phenomena with BAX and BAC is happening on the surface of the mitochondria. Okay? It's actually quite simple, you know, and it's quite fascinating. And so now we use a drug that will actually block BCL2 and prevent BAX and BAC from being sequestered by these anti-apoptotic proteins. And that's a drug called venetoclax. When you block that, now the BAX and BAC, there's excess of BAX and BAC, they start sequestering on the top of mitochondrial cells, and they start leaking hydrogen, and the cells get damaged because they can't produce energy. But interestingly, many of these drugs that target the mitochondria are not very effective by themselves. They kind of prime the cells to undergo apoptosis, but you sometimes need a little bit of chemotherapy. So venetoclax, for example, though it sequesters BCL2, is inadequate to kill cancer cells. To give a little bit of chemo with it, fantastic, okay? So that's a concept called priming, and I want you to try and understand it this way. If you have a container, which is your apoptotic level, amount of apoptotic damage that you can take, okay? So your resistant AML cells can take much more damage before they'll undergo apoptosis, okay? Your normal cells, for example, will also ideally take a lot. Now imagine if you could fill in something into that container, okay, which would actually reduce the amount of chemotherapy that you will need to make it overflow into apoptosis, okay? That's the concept of priming, okay? So if you have a container that measures apoptosis, you need a lot of a drug to get apoptosis. But if you fill that container with something that now tells you I need much less chemotherapy to overflow and cause apoptosis, that's the principle of priming. The other way to understand priming, if you've lost me over here, is like you're on a slope of a hill at the end of a cliff, okay? Priming is pushing the cells right to the edge. And then you give him a little chemotherapy and he's off the cliff and he dies. The other end, he's at the bottom of the cliff. You have to give him chemotherapy to drive him to the top of the cliff to die, okay? So many of these drugs that target the mitochondria, like the drugs that I'm going to talk about, actually do what's called priming, okay? Okay, so now in cancer, there's an interesting phenomenon. I'm sure many of you all have heard about it. It's called the Warburg phenomenon, right? So for reasons that is probably evolutionary, cancer cells, even in the presence of abundant oxygen and nutrition, prefer the anaerobic pathway, okay? The anaerobic glycolysis. And if you remember, there's something that's very important in the anaerobic glycolysis pathway. When there's an overflow of that, there's an increase also in the pentose shunt pathway. So we had a 6-carbon molecule for glucose. It came to a 3-carbon molecule called pyruvate. But if it goes the other way into a 5-carbon molecule, what do you end up with? Very simple, ribose and deoxyribose, okay? So that tells you that pathway is very critical for nuclear proliferation, okay? So now, if you put 2 and 2 together, when you have anaerobic glycolysis, cancer cells have all the ingredients for nucleotide synthesis and rapid proliferation. In addition, glycolysis and OXPHOS, in terms of energy production, you can visualize it like this. Glycolysis is super fast in producing energy. It's like one of those super hyped up cars, that can go from 0 to 100 in 2 seconds, but will consume a gallon of fuel to do that. While OXPHOS will take you from here to Vellore with 1 liter of fuel, but is very efficient, but will generate energy at a very slow pace. And cancer cells need energy rapidly. And they need all the byproducts that are required for the cancer cell to proliferate, okay? Now, in contrast to many cancers, in AML, now this is, you have to just accept it, okay? There's a lot of information, there's a lot of data that already says, in contrast to many other cancers, AML relies more on OXPHOS, oxidative phosphorylation, and in addition, the cycle is predominantly fed by fatty acids, not by glucose or amino acids, okay? Fatty acids, and especially very long chain fatty acids. So the story goes like this. You have long-chain fatty acids that are picked up by CD136, moved in the cytoplasm. In the mitochondria, there's an enzyme called carnitine-palmitoyl transferase that moves it into the cytoplasm. And there's an enzyme called very long-chain fatty acid dehydrogenase that converts it into acetyl-CoA. That then feeds the Krebs cycle. And this, it's not like in anything in biology is exclusively one or the other, but in AML cells, it seems that this is the predominant energy driving pathway. So people have tried to target this pathway. They've tried to block CPT1, etc., but none have been very successful. So this paper, I just illustrate this paper because in this paper, they tried to essentially block this enzyme. Based on a lot of proteomic data, they came up with a concept that VLCAD is an enzyme is very important because AML cells require very long-chain fatty acid dehydrogenases as a major mechanism of energy production. So they actually developed an inhibitory molecule of VLCAD, and they were able to demonstrate that this is druggable in a dose-dependent fashion. It can kill AML cells. Far, far more important, it was specific. That means it didn't kill normal cells. It killed only the leukemic cells, while it spared normal cells from kill. Okay? Now, if you were to block an enzyme called VLCAD, which is utilizing your very long-chain fatty acids, what do you expect to see? You expect to see a buildup of the long-chain fatty acids, right? If you put a block anywhere, upstream molecules will increase. Okay, and that's exactly what they show. They show that the C16 long-chain fatty acids build up when they use an inhibitor of VLCAD, okay? And in summary, they basically say that in AML cells, there's a block. If you block VLCAD, you can kill the cells because like anything in biology, when you block one pathway, the other pathway tends to get switched on. And here, it's the pyruvate dehydrogenation, the glycolysis pathway that gets switched on. But in cancer cells, they argue that that's not good enough for the cell to survive. But in a normal cell, on the other hand, if you use that same molecule, even though you inhibit VLCAD, the glycolysis is able to make the cell survive. Okay? So this is what to some extent was work that progressed from my arsenic trioxide work. We went on from treating patients, looking at the biology of arsenic trioxide in the lab, okay? And we tried to ask the question, why do some cells, when they become resistant to arsenic trioxide, why are AML cells, which are very much like APML cells to some extent, not sensitive to arsenic trioxide? Okay, and to cut a long story short, what we demonstrated is two things. One is arsenic trioxide, in addition to PML-RAR degradation, is also a glycolytic inhibitor. Okay, and we demonstrated that if you use arsenic trioxide and you use a small molecule called FCCP, which can basically disrupt the outer membrane of the mitochondria non-specifically, you can restore sensitivity to arsenic trioxide, and this combination, just ATO with FCCP, can kill all AML cell lines. Okay? The problem with that was that it was not specific. That means it killed cancer cell lines, but if you just focus on the peripheral blood mononuclear cells, the combination also killed peripheral blood mononuclear cells and normal CD34 cells. So it's not very effective. If you're going to kill everything and the normal cells, you're not going to think. So the challenges, that illustrates to some extent the challenges that have been there in the field, before the work that we've been doing. One of the concepts is metabolic adaptation. And many people have tried this, and there's many publications out there. They try to block a dominant pathway, the cell switches on another survival pathway, okay? Another energy generating pathway. Or you find a very effective molecule, like this molecule called IACS0107, which was a complex 1 inhibitor, okay? And when they did that, they ended up with severe lactic acidosis because there was very significant off target. So it was not only blocking this in the cancer cells, it was also blocking complex 1 in all normal cells. And when all normal cells shift to glycolysis, you end up with massive lactic acidosis. So these have been some of the challenges. So from the work that we did, we were very interested in trying to find an OXPHOS inhibitor that is specific only for AML and does not inhibit normal cells OXPHOS, okay? And there was a publication out there, as there are for many things. When we did this search, there was a group that had studied molecules, almost 5,000 molecules, and how they impact metabolism, okay? So it was fascinating for us that there was a whole lot of anti-malarial drugs that could actually block OXPHOS, okay? And that's when we actually collaborated with Dr. Sanjeev Krishna, and this is a publication. Again, I'm not going to go through the details of every experiment that is there, but for those who are really fascinated by this, I encourage you to read this paper because it has all the details of the experiments, which I can't possibly cover. But the key elements are, we worked with Dr. Sanjeev Krishna's lab, and we looked at ATO with a whole lot of molecules. And the molecule that really stood out was a drug called artesunate, which is used for malaria, treating malaria. And this also takes you back to China, to you who won the Nobel Peace Prize. You know how they went about getting artesunate? They were losing more patients in the more soldiers in the Vietnam War than from malaria than from actually losing on the battlefield. So in typical Chinese fashion, she put 5 institutions were told to go and screen for all molecules possible for malaria. And they just went about methodically doing. So if 2UU comes and presents, she's a very unimpressive presenter. They methodically went about it, and they came up with this molecule, with this plant derivative called artemether. It was, and a derivative of that is artesunate, which was very effective in treating malaria. And you have it only in IV form. Do you know why we don't have oral form? It was a WHO decision. It's easily available, it's well absorbed. But the WHO is very scared that it will be abused off the counter, so they just stopped worldwide manufacturing oral artesunate. So it's only available in an IV formulation, okay? So this comes back to the effect of artesunate with ATO. What I'm showing on the left side is normal healthy mitochondria. Here we call any drug that targets the mitochondria mitocan. When you combine ATO with artesunate, you can see the damage that is being done to the mitochondria. Visibly you can see fragmentation of the mitochondria, okay? Now, why does artesunate work in cancer cells and does not affect normal cells? Why does artesunate work in malaria? Okay? So it's fascinating. Artesunate, if you were to conceptually visualize it, okay, it's not exactly true. It's almost like it's a molecule with an oxygen molecule held inside, okay? And it does not bring about its oxidative or damage. It's like a nuclear warhead that's well hidden. When it's given iron, it undergoes a conformational change, and literally the oxygen molecule comes out, okay? And it comes out in areas where it's rich in iron. So your red cells, where the malaria resides, is rich in iron. Okay, and that's why it causes damage over there. Now, cancer cells, fascinating, folate receptors and transferrin receptors are sky high in cancer cells. It reminds you of a fetus, okay? The mother can be 0 iron, but the fetus will never be 0 iron. It will suck the last amount of iron from the mother, okay? It will never be. So cancer cells are almost like that. Even if you have iron deficiency, the cancer cells are rich in iron, okay? And this is one of the reasons how specificity of artesunate is brought about in AML. And we can actually show that when you do this, and if you actually chelate the iron, you can see that you lose the effect of the artesunate on cancer cells. And also when you give artesunate, because artesunate literally in the cell chelates the iron, what will happen to the normal heme synthesis in the cell? The hematologist here, sorry, this is not a hematology crowd, but for a hematology crowd, in the mitochondria, you get a buildup of protoporphyrins because the last element in the heme synthesis is incorporation of iron. If there's no incorporation of iron, you essentially end up with porphyria in that cell. And when you have accumulation of porphyrin in that cell, you automatically have autofluorescence. Porphyrins are autofluorescence. So when you treat these artesunate cells, you can actually see a shift in the autofluorescence, the FL2, when you treat them with artesunate. It kind of tells you, compared to normal cells, how it is relatively specific for the cancer cells. We've done a lot of laboratory in vitro work showing that the combination of ATO-ART is as effective as ventricular plus azacitidine. There's a lot of seahorse experiments. Again, because I told you so much about mitochondria, now you should be able to understand it. You see the basal oxygen consumption rate is high, okay, when you give artesunate. It's basically, imagine the membrane is damaged. The mitochondria now keeps consuming oxygen. Why do you consume oxygen? The only reason you consume oxygen is to maintain the intermembrane hydrogen concentration. But now the mitochondria's membrane is damaged. But it's consuming oxygen is not able to generate enough hydrogen gradient, okay? And therefore, because it cannot generate enough hydrogen gradient, it follows. The oxygen consumption rate is high, but the ATP production is rock bottom, and the proton leak, which can be measured, is sky high. Okay, it just follows logically what we said follows. Okay, and this is basically damaging the mitochondria where there's increased consumption of oxygen, but there's no consumption. So it's called uncoupled respiration. Okay, so this is the phenomenon of uncoupled respiration. We also did some proteomic pull down. We basically labeled artesunate, put them in the cells, and said, what all molecules does this artesunate bind with? Okay, and we pulled down the artesunate. Okay, there are methods to do that. And we found that it binds to a whole lot of molecules, many of them which are involved with fatty acid metabolism in the cell. And very excitingly, it also bound to ACADVL, which is the name for the gene called VLCAD. Okay, so it binds to that same enzyme that the other people published a small molecule can inhibit, can be effective in treating things. So we know that artesunate from this study binds to VLCAD, the enzyme. So the next question was, if I knock down VLCAD, will it replicate the effect of artesunate? Is artesunate actually inhibiting VLCAD? We don't have a direct measure of it. So when you knock down VLCAD and you do with ATO, you get the same combinatorial kind of effect of kill with ATO and artesunate when you knock down VLCAD, saying that probably artesunate is predominantly working through this way. This is how basic science goes. Then you do the opposite. You overexpress the VLCAD and say, will this completely negate the effect of artesunate? And we show that as well. Okay, so you overexpress the VLCAD, and then you show the artesunate makes no difference if you add artesunate. It does not cause a kill by itself. But if you don't overexpress it, the ATO-ART kills. If you overexpress, the ATO-ART doesn't kill. Suggesting that at least one prominent pathway by which the artesunate is working, in addition to its damage on the mitochondrial membrane, is by inhibiting VLCAD enzyme. Okay? And if it's inhibiting VLCAD enzyme, the sequence should follow, right? You're blocking an enzyme, upstream things should accumulate, okay? So in our untargeted metabolomics, we can actually show an accumulation of C16, C12, the long chain fatty acids, okay? So this is all published data, and we went on to do a bioluminescent animal study. This was done in the UK with my collaborator, okay, where we show the combination of ATO-ART effectively kills the cancer cells compared to other drugs, okay? So this has now moved to a clinical trial. We are right now in the phase 1 clinical trial. Basically, we want to replicate what we did with APML in AML. We want to treat 100% of our patients at low cost with the drugs and therapies that are easily affordable and accessible to everybody. That's the dream. Okay, so I'm not going to go into the details of the study design. Okay, so this is a phase 1 ongoing study with Dr. Manju, Smita, and from TMH and JIPMER. I'm just going to show you some unpublished data just to show you the excitement we feel about it. Okay, so this is the third cohort of patients where we are actually using low-dose chemotherapy with cladribine, low-dose cytosine with Ven, ATO-ART at very low doses. And this is the group of 9 patients. We need 10 patients on this cohort before we move to the phase 2 study. Relatively young patients, like you'll see in any center in India, nothing very specific. Most of them are intermediate risk or high risk. There's no selection here. It was basically based on how the patients landed up in our center. It was not based on we looked only for good risk patients, etc. Okay? And when we treated them with one cycle of chemotherapy, what I'm really trying to highlight is, I know the hematologist oncologist will be excited, but the rest of you will be like, what is this guy so upset up about? It's like 90% CR, okay? And 6 of them are what we call measurable residual disease negative, okay, with one cycle. And beyond that is this. The WBC count These patients are treated in general ward. We in CMC never used to treat these patients in general ward. They all sit in general ward. They sit there like, what's going on? Nothing's happening, you know. And 14 days, almost to the dot, by 18 days, their counts will start recovering. Okay? And what you're seeing low on the lower side is actually the fever pattern for all those 9 patients. You can see most of them have fever in the 100, 101, 2 range. This one patient died on day 10 of 12 or 12, 14 from an infection, unfortunately an iatrogenic infection at the bone marrow site, which is very sad. So very well tolerated, transient transaminitis for the most patients tolerated very well. We had 1 death and excellent response and rapid recovery in counts with very little off-target side effects. So combining ATO and artesunate was well tolerated. ATO and artesunate with low-dose chemo and venetoclax was also well tolerated. Efficient priming with this combination is what we feel is going on. Not only is efficient priming of the blast to be killed with this combination, but very little off-target side effects. No mucositis, no hair loss, you know, patients look absolutely fine. There's a lot of basic science data in this, in the preclinical publication, where we show potential even in venetoclax resistance. Combination therapy with minimal off-target effects, mild self-limiting transaminitis resolved in stopping arsenic trioxide for a few days. Significant efficacy, remember this is a phase 1 study, I don't want to read too much into the efficacy. We need to validate with a phase 2 multi-center trial that will start soon. The low cost in view of the limited duration of neutropenia, off-target side effects, and hence support required is very low. So we're quite excited, and we hope that, you know, again, there's a long way to go in terms of trials and studies, okay? But again, just to acknowledge, it takes a lot of people over many years, you know, for all this work to evolve. Dr. Sanjeev Krishna, clearly my collaborator, students over the year, a lot of this work was done by Nitya Balasundaram and Christine Shomin and Anna, who helped us actually set up the animal facility in the early days. Funding from Welcome DBT Alliance I would have not done without them and the Team Science grant that I have right now. So thank you for your attention. I hope I didn't blow you with biochemistry over here. Okay. Thank you so much.
Thank you, Dr. Vikram, for taking us on that journey. I would like now to call our director, Father Jesudas, our president of the Alumni Association, Dr. Anthony Robert, and our vice president, Dr. Priya Pais, to felicitate Dr. Vikram Matthews.
Thank you so much. Thank you. Come on. Thank you. Hey, thank you. Seat, no? I can't sit down.
No, you have to sit.
Come on, it's ridiculous. I can't be sitting.
No.
I feel very odd.
No, please stay.
You better we just stand here.
But this is Karnataka.
Okay.
Well done, Dr. Isha. You did it.
Anjali.
Not allowed. One picture. You can stand. You can stand. Come. Since you're more comfortable standing. Come. This is Bangalore.
It's Bangalore.
Thank you.
Thank you.
Thank you.
Thanks.
I'd like to call Dr. Priya Pais to deliver the vote of thanks.
Dr. Vikram, thank you so much for an enthusiastic, inspiring, and really enlightening oration on myeloid leukemia. As a non-hematologist, I think I learnt a lot, and I enjoyed going back to biochemistry days. Thank you to Dr. Rajalakshmi and Dr. Sharath for graciously introducing Dr. Jayashree Thomas and Dr. Vikram himself. We are grateful to Reverend Father Yesudas and members of the St. John's administration for their support in conducting this oration. Thank you, Dr. M.J. Thomas, Dr. Maya Thomas, for joining us here, and to your family for joining us online for this oration. Special thanks to Dr. Tony Raj, Dean of the Research Institute, and of course distinguished alumnus, for giving us the opportunity to host this oration in this wonderful venue. Thank you to the team from our Alumni Association Executive Committee, led by Dr. Anjali Olapalli. Thank you for organizing and coordinating this afternoon's events. A big round of applause for her. And most importantly, I'd like to thank everyone for joining us this afternoon. I think you will agree that this has been a most stimulating oration from such a distinguished speaker. Thank you, everyone. Tea announcement. Tea is served outside.
Just put her to sleep.
Sorry, sir.
Hey, thank you so much.